All right. Good morning, everyone. This is Heidi Brown. If you can't tell, I'm logged in under Christy Lincecum's name because I'm in McConnell's conference room all by myself. So if you're around, please come join me. I'll put my mask up. It is my absolute pleasure to introduce Dr. Candace Parker-Autry for this morning's Grand Rounds. Dr. Parker-Autry and I have known one another since we were on the fellowship application trail together. So we've gone back a long time. She is currently an assistant professor in the Department of Urology at Wake Forest Baptist Health. And she got her Bachelor's of Science at North Carolina Wesleyan in 2001. She did her medical school at Wake Forest, where she is now. She then moved to Philadelphia and did her residency at the University of Pennsylvania. And she did fellowship at University of Alabama in Birmingham. And then she took her position at Wake Forest. She is fast emerging as a leader both in urogynecology and in geriatrics. Her research focuses on urinary incontinence as part of a geriatric syndrome in much older adults, women 70 and older, I believe, but she'll tell us more. And she recently submitted one of the most prestigious K Award applications that you can submit, which is called a BESON, for people who are anticipated to be leaders in aging research nationally. So we are really lucky to have Dr. Parker-Autry here sharing some of her work with us this morning, especially because she is currently on vacation in Jamaica with her husband on a much needed parents-only vacation. And she is taking an hour out of her vacation to share her incredible work with us. So I'm going to go ahead and mute and let Dr. Parker-Autry get started, but I just want you all to join me in thanking her in the chat for being here because we are really lucky. Okay, thank you, Dr. Parker-Autry. Take it away.
You are so sweet. I so appreciate this opportunity to be here with you all. I'm very grateful to Dr. Brown for thinking of me in terms of this opportunity. So my only disclosure is that I am in a small cafe in Jamaica. My connection's great, so hopefully we don't have any issues. So in this talk, I want us to spend some time reviewing the concept of urinary incontinence and geriatric syndrome and review key clinical characteristics of aging that contributes to how incontinence changes from a condition to a syndrome. I want to also highlight important gaps in knowledge regarding treatment approaches for urinary incontinence in older women using the lifespan model for incontinence. And then I want to review our current knowledge and the conceptual models that we're using right now for geriatric urinary incontinence, the syndrome, and to potentially discuss future therapeutic interventions. So healthy aging is our future. Wisconsin itself has approximately 15% of their total state population being adults older than 65 years, the majority of whom are going to be women. And our future in healthy aging is women's health. So listen, everybody, we have a lot of job security. It's important because we have succeeded in our country with increasing the lifespan or life expectancy from 1950 to 2016. As you can see here in this figure, among older adults, there are higher numbers of women with an average life expectancy of 81 years. As women serve as the caregivers for their families, it's very important we prioritize their health, as oftentimes they are unable to. Healthy aging is also important because, as this chart demonstrates, the likelihood of having a disability, such as poor physical or sensory or cognitive function, poor hearing or vision, this all increases with age. In fact, more than 50% of older women live with disabilities such as poor physical performance, difficulty with function or executing tasks, dementia, or other cognitive impairments. So healthy aging is the future of women's health. And when considering how to impact on health and aging in women, incontinence must be at the forefront of our minds. Why, do you ask? Well, the chart on our left summarizes 13 different studies and shows in the red box that after the age of 65 years, more than 50% of all women will develop some measure of urinary incontinence through their geriatric years. And looking towards our right, the red line in this graph demarcates that incontinence symptoms become more severe and bothersome with increasing age. As I began my practice at Wake Forest, I noticed that some of my favorite older patients would do great with some of our standard therapies, such as slings or Botox therapy, but some would not. And I wanted to understand what would cause some older women to fail our therapies. So I then went to examine some of the better known trials focused on older women with incontinence. And I found, for some reason, my figure is not showing here. But basically, the average age of women included in the major studies for the effectiveness of standard treatments for incontinence is 55 to 65 years. And this is including the Atlas trial, the Rosetta trial, the ABC trials, and B trial. These are all very highly recognized trials in the urogynecology world that establish some of the efficacy of our baseline treatments like incontinence and medication management and Botox therapy. Because the average age is 55 to 65 years, we tend to know very little about how to treat urinary incontinence in older women that's now considered older than 70 years. As a result, we have many treatments applied to older women with two issues. One, we do not understand how incontinence in geriatric women is different. In essence, we are not just dealing with urethral hypermobility. And two, we lack understanding of how to treat this condition in older women. For example, Bergio and her colleagues conducted this clinical trial that examined the efficacy of group-based pelvic floor therapy to treat urinary incontinence in older women and revealed that there is significant decrease in incontinence episodes among women after group-based therapy, with baseline urinary incontinence episodes being 1 per day and a decrease to 0.3 episodes per day. A critique for this paper is that the mean age was only 64 years, with a standard deviation of 7 years. Given that we now know that women are living 20 years beyond this point and having the onset of urinary incontinence after the age of 70, we still have a gap in knowledge in terms of how effective pelvic floor muscle therapy is in women older than 70 years. In addition, it's hard to characterize. In addition, in this particular cohort, they recruited women who had more mild episodes of urinary incontinence with 1 per day. So if we think about medication management, Midloff and colleagues reviewed the effect of pharmacologic treatment for urinary incontinence in the elderly and the frail. And they revealed that most medications may decrease incontinence episodes by 0.3 to 1.2 episodes per day in this population. Since we know that urinary incontinence in older women tends to be more severe, the impact of this modest decrease is important to characterize. Therefore, these authors concluded that anticholinergics have a small, although statistically significant, effect on urinary leakage in adults with urgency incontinence. So treatments with medications in the elderly and the frail may not be evidence-based. We consider posterior tibial nerve stimulation. This is a very common therapy that we tend to use before we get to interventions like Botox or sacral neuromodulation. But with posterior tibial nerve stimulation, Schreiner and colleagues conducted a randomized controlled trial comparing bladder retraining with or without Ptns. They were able to find that the addition of Ptns with bladder retraining resulted in a reduction of urgency urinary incontinence episodes by 68%. So you can imagine if a woman has mild incontinence, so less than 1 or 2 episodes per day, this may be a significant enough decrease that may be impactful for them. But if they're having really severe incontinence, it's unclear how effective this will be. In this trial, the Pelvic Floor Disorders Network, they conducted a secondary analysis of the Rosetta trial that examined the efficacy of intravesical Botox treatments compared to sacral neuromodulation. In this secondary analysis, they aimed at determining the impact of age beyond 65 years on the efficacy and morbidity of these treatments. This analysis revealed that younger women had a greater absolute decrease in urgency urinary incontinence episodes. They also had more symptom improvement. They had fewer UTIs. After Botox treatment specifically, younger women had a 3.3 higher odds of having a greater than 75% reduction in their urgency incontinence episodes compared to women who were older. So in essence, both Botox as well as sacral neuromodulation were demonstrated in this study to have decreased efficacy and higher risk for morbidity in older women. If we consider this study done by Anger and colleagues, this is a Medicare-based analysis that evaluated postoperative outcomes of midurethral sling procedures for stress urinary incontinence, and they analyzed it based on age. They concluded that among women older than 75 years, they were more likely to experience postoperative urgency incontinence, more likely to experience treatment failure after slings, outlet obstruction leading to voiding difficulty. In addition, comorbid conditions were associated with higher risk or higher rates of non-urologic complications after this procedure. So as we consider these data, I thought critically about my observations and hypothesized that my patients who failed our standard therapies were not those exhibiting differences in how they were aging, were those who were experiencing differences in how they were aging and differences in their physical performance. So if we look at this picture, those who are on our left are clearly visibly having mobility disabilities, potentially with accompanying physical function impairments. And these are distinct in comparison to those on our right that appear highly active, much more healthy and independent with mobility. So at this time, I think we were at a place where we were basically doing a one-size-fits-all treatment algorithm for women who have urinary incontinence. However, these differences in aging that we see on our left compared to our right plausibly demonstrate important differences or important features of unhealthy aging that may impact on the success of our current treatments. So the fact that urinary incontinence is a geriatric syndrome was news to me as a board-certified urogynecologist when I first learned about this in 2014. However, it was very well established in the geriatric world long ago because in older adults, both men and women, is a multifactorial condition that's very prevalent among older adults with multiple potential causes and contributions and pathogenic pathways that result in incontinence. So here we demonstrate basically a linear conceptual model that has been historically used to demonstrate how geriatric syndromes present themselves. In 2016, the American Geriatric Society and the National Institutes of Aging published their report at the 9th Bedside to Bench Research Conference entitled Urinary Incontinence in the Older Adult. And they featured this conceptual model that revealed the multifactorial nature of incontinence of older adults that may result from brain aging that regulates physiologic stressors, cognition, mobility, and more local environmental factors such as renal function impairments, fluid shifts, colorectal function, age-related bladder factors, and changes in the GU structure. So it was really important to know that in this conference, as well as in this paper, it's highlighted there are a lot of some gaps in knowledge. So I really want you to understand this principle of the geriatric syndrome. So we will go through this very common conceptual model that's used more commonly now. With aging, there is increased onset of cognitive impairment, physical function impairment, and impaired mobility. These shared risk factors that you see in this box on the left present as difficulty with thought and memory, difficulty with executing tasks, and difficulty with mobility. When present together, they are shared risk factors for conditions known as geriatric syndromes, which is listed in the box in the center. And it includes incontinence, falls, pressure ulcers, delirium, and functional decline. These conditions are coined syndromes because they all have these shared risk factors that may lead to frailty and ultimately increasing the chance of loss of independence, institutionalization, as well as death. My take-home point is that incontinence in older adults is a geriatric syndrome reflecting a complexity that's very poorly defined. We do not have a mechanism of clinically recognizing this as a diagnosis. As a consequence, we as a healthcare system and providers for this community of hundreds of thousands of aging women that may have this geriatric incontinence syndromes are completely ignorant in how to identify them and how to treat their incontinence more specifically. We must do this work towards filling this gap in knowledge because 62% of older women will have a disability and difficulty with completing tasks as well as having incontinence. And they have a threefold higher risk of losing independence with executing tasks. When I examined how much research is going on into the most common geriatric syndromes, funding and efforts are highest, as we all know, for dementia and cognitive impairments, and lowest for incontinence. In fact, we have learned very little about the complexity of incontinence in the geriatric population in the past 20 years. To begin to investigate this issue, I initially felt like I was looking up at a big giant sequoia that you'll see out in California, but through my excellent mentorship as we develop more of this science, I know that instead of cutting this tree down, we had to start to chisel through it. So to begin our investigation into why urinary incontinence is a geriatric syndrome, we aim to build upon the knowledge that in aging women, functional impairment and muscle weakness was common. We also knew that in aging women, if you follow that red arrow, that urinary incontinence develops at a higher percentage in women older than 70 years. However, these dotted arrows kind of show relationships that we did not know at this time. We did not know how the geriatric risk factors of functional impairment and skeletal muscle loss or weakness interrelated with the development of urinary incontinence. So we started with women in the health, aging, and body composition cohort to understand what functional impairments were present as women became incontinent. Looking at sarcopenia or muscle loss and weakness as a potential mediator to the relationship of how functional impairment and urinary incontinence were associated. So we started with this cohort of healthy women older than 70 years without urinary incontinence symptoms. Women who developed urinary incontinence symptoms composed of our exposed cohort, and controls were women without urinary incontinence at year 4. We then looked at the change in their physical performance from baseline to year 4. Our important findings were that 33% of older women developed urinary incontinence when observed over 4 years. Older women who developed urinary incontinence also had significant declines in their physical performance, indicating functional impairment. The most impactful driver of this decline in function was a significant decline in standing balance. Older women who developed urinary incontinence also had a twofold higher risk of concomitant development of significant weakness or sarcopenia. So we learned that as women age and develop urinary incontinence, they did become more functionally impaired with greater skeletal muscle weakness with apparent changes in balance. Thus far, we have developed treatments for women with urinary incontinence that range from non-surgical through surgical approaches. We did not consider these age-related changes and how they may impact how successful our treatments would be. So what is happening with aging that may drive this observed differential efficacy in incontinence treatments? What I want to do is kind of introduce you to conceptual model developed by John Delancey, who is viewed very strongly as the father of the science of pelvic floor conditions. Alongside his colleagues, he created this lifespan model as a graphical display of phases of a woman's life and then proposed the early concept of deficit accumulations with aging towards a threshold to the onset of pelvic floor function. So if you can see here in this figure, there's a line that crosses around the age of 70 of symptom threshold. So once the pelvic floor function decreases below that threshold, that's indicative of onset of symptoms. So this model considers 3 life phases. Phase 1 represents childhood, when the pelvic floor grows and develops. There's typically a great functional reserve of pelvic floor function. And during this phase, there are predisposing factors such as genetics of collagen, skeletal muscle and smooth muscle development, ethnicity, anatomic and environmental factors. They all may affect the growth and development of the pelvic floor and may be important to the functional reserve and capacity of pelvic floor function. Phase 2 is where inciting factors such as pregnancy or childbirth play a role through potential pelvic muscle or nerve injury. Exposure to pelvic surgery or radiation, chronic increases in intra-abdominal pressure, such as with obesity or constipation, heavy lifting, or chronic cough, can also be inciting events. These events or hits to the pelvic floor function may have consequences on the functional reserve of the pelvic floor. Then, in phase 3, there are age-related changes such as menopause or age-related changes in the urethra, the pelvic floor. The effects of polypharmacy and multimorbidity may also have an impact. Disability may be more present in this phase, as with other factors that may contribute to the development of pelvic floor dysfunction like urinary incontinence. So let's look at this a little bit more carefully. In considering phase 1, there are variations in the growth and development. So pelvic floor development, like height, is influenced by factors such as the individual's genetic code, nutrition, and environment. Line A in this figure refers to an individual who develops excellent pelvic floor function, and she may never have a sufficient deterioration in her pelvic floor function or reserve to develop pelvic floor symptoms throughout her lifespan, despite any kind of inciting or lifestyle events. However, another woman whose growth and development are less robust, for example, line C, may become symptomatic during her lifetime solely on the basis of normal age-related decline. Consequentially, then, the role of genetics must be considered in analysis of pelvic floor dysfunction and its causation. Phase 2 accounts for inciting factors such as pregnancy and childbirth. Even with substantial or dynamic changes in the pelvic floor during childbirth, return to normal function, as you all know, or normal functional capacity occurs for most women. The fact that one woman can deliver several large babies without developing pelvic floor dysfunctions, whereas another can have significant problems after a single birth or relatively small infant, indicates how little we know about the true impact of this process on the pelvic floor. So depending on phase 1 events, a woman may have no increase in the risk of developing pelvic floor disorders, despite the experience of potential inciting events. In the figures, it basically shows that there are different degrees of functional impairment after vaginal birth are shown. A delivery that does not permanently injure any structure beyond the body's ability for repair, such as in line A, may not affect the individual's development of symptoms later on in life. However, a more significant injury, like in B, for example, there's partially healed, that may reflect a partially healed injury of the pelvic floor may decrease the functional reserve, therefore leading to earlier occurrence of symptoms. A severe injury, such as in C, you can see that line dips down and symptoms start immediately. In these women, symptomatic disease may occur pretty immediately, and that person may never recover any of their pelvic floor function. So John Delancey proposed that factors throughout the lifespan in phase 1 and phase 2 should be considered, as well as in phase 3, should be considered independently, interactively, as well as cumulatively. And I hypothesize that this cumulative impact of lifespan occurrences is what's most important in contributing to the incontinence of aging that we have now coined as the geriatric syndrome of incontinence. So when this was discovered, it was somewhat like, rolling the stone away. And John Delancey's work has been very impactful, and he's actually been very impactful with developing the conceptual framework of the geriatric incontinence syndrome. It's important to consider why are these changes happening? Why are we losing functional reserve, and what is happening specifically with aging? So it's well known that aging changes our skeletal and smooth muscle physiology. And as these changes also affect the pelvic floor. Specifically, age-related sarcopenia is an important determinant of skeletal muscle weakness associated with poor health consequences in older adults. There are marked alterations in muscle architecture that are caused by aging that result in loss of sarcomeres. From a functional point of view, decreased sarcomere number alters muscle length and tension, as well as the force velocity relationships of skeletal muscle. And these changes in muscle architecture account for about 50% of the loss of function in older adults. And the part that I'm sorry that you can't see because the slide is cut off in this presentation, there's also an abnormal accumulation of collagen in intramuscular and extracellular matrix and skeletal and smooth muscles that may also impact this function. So Alperin and colleagues examined whether these changes are happening in the pelvic floor. So they looked at pelvic floor muscle architectural changes that may occur with aging after vaginal delivery compared to those who are nulliparous. And they found that aging versus parity was more associated with decreases in physiologic cross-sectional area of all pelvic floor muscles, was also increased with decreased physiologic cross-sectional area of pelvic floor muscles, as well as shorter sarcomere length and increased intracellular collagen. And these collaboratively or collectively result in lower active force of muscles. So that's a more sophisticated way of saying that with aging, there's smaller pelvic floor muscles, they're weaker pelvic floor muscles, and therefore they're likely to be less functional pelvic floor muscles. Because of these realities and kind of given this cumulative knowledge, the original conceptual framework that we started off with the Health ABC study evolved to now consider that we are likely being posed with treating a population of older women with moderate to severe urinary incontinence symptoms and concomitant functional impairment with potential sarcopenia. We have not previously considered this specific population in our prior trials, so we don't know how well our standard therapies work for this specific cohort of women. So I designed a prospective cohort study aimed to gain more knowledge on the impact of pelvic floor muscle training on urinary incontinence symptoms. My central hypothesis is that there is a global skeletal muscle dysfunction that may be contributing to the onset of more severe and refractory urinary incontinence in older women. And this would make our primary non-surgical treatments potentially less effective because they're skeletal muscle based with pelvic floor muscle exercises. So I wanted to quickly introduce you to the short physical performance battery because this kind of is the crux of what we use to examine the role of physical function impairment in urinary incontinence treatment, specifically with pelvic floor muscle training. So the short physical performance battery is a comprehensive, validated evaluation of physical performance, balance, and strength. And this was used to assess our primary outcome, which was, does physical function impairment, which may reflect significant changes in skeletal muscle health, is this potentially a predictor of lack of efficacy or decreased benefit of pelvic floor muscle and first-line treatments for urinary incontinence in older women who have concomitant functional impairment. So these are the results of this prospective cohort study. And this basically shows, I'm sorry, you can't really see. Bottom of the slide. But I'll talk you through it. There are no significant, we didn't find any significant differences in demographic features at baseline. Urinary incontinence episodes we basically divided up our cohort into those with severe urinary incontinence, defined as those women with 2 or greater leaks per day, and those with moderate urinary incontinence, those with 1 or less leak per day. And of course, those with more severe incontinence in this cohort had a mean number of incontinence episodes of 4.8 per day, compared to 0.9 or 1 or less per day in women with moderate urinary incontinence. This is really important because in many of the prior trials that investigated the efficacy of pelvic floor muscle therapy specifically, they only looked at women with mild to potentially moderate urinary incontinence. So typically urinary incontinence episodes of 1 or less per day. So our cohort was really unique in many ways in that we were able to successfully recruit older women. So everybody was older than 70 years. Everybody had at least at least moderate to severe urinary incontinence. And we were able to compare women who had functional impairments with those who did not. When we look at pelvic floor health and strength, older women with more severe urinary incontinence had weaker and less efficient pelvic floor muscles. And you can kind of see, the way this is presenting is a little bit off, but if you look at the first line, women who had more severe leaks, so 2 or greater, had weaker pelvic floor muscles at 21.8 compared to 29.6. They also had less efficient pelvic floor contractions. If you look at the last line, the last row, the number of fast contractions per 10 seconds, this is a measure of pelvic floor muscle efficiency. So they were able to only do 4 fast contractions after doing their pelvic floor muscle training in comparison to 5.1. So this kind of goes along with our theme that women who had more severe urinary incontinence were also those who had more significant pelvic physical function impairments, and they also have weaker muscles, and this is at baseline. We looked at our baseline differences with disability. Women who had more severe urinary incontinence also had greater difficulty with walking a quarter of a mile. They had difficulty with walking up a flight of stairs. The PAT-D and the MAT-SF were validated assessments of perceived difficulties with mobility, with physical performance. And in both of those categories, women with more severe urinary incontinence also had greater perceived difficulties in these areas. This slide highlights that poor physical performance was significantly associated with urinary incontinence severity as well at baseline in this cohort. So if you look at SPDB scores, a score of 9 or less is our primary indicator of significant physical function impairment. And those with more severe urinary incontinence had a score of 9 versus 10 in those with more mild to moderate incontinence. And you also should look at the fact that women who have more severe urinary incontinence also have slower gait speeds. So both physical function impairments as well as gait speeds are significant markers in the geriatric literature as those who have a higher risk for institutionalization as well as for frailty. So if we look at the cohort results, and I kind of just summarized it in this slide. And this table is looking at the change in urinary incontinence episodes, symptom bother, pelvic floor muscle strength from baseline to 6 and 12 weeks, categorized based on physical function impairment status, with SPDB less than 9 defining the presence of physical function impairment, and a score greater than 9 indicating normal physical function. It's important to note here that after 6 weeks of pelvic floor training and behavioral therapy, incontinent women with physical function impairment experience a non-significant but greater decrease in urinary incontinence episodes at negative 1.3 compared to women without pelvic physical function impairments, which was at negative 0.5. So the first thing to note in this particular cohort of women older than 70 years with moderate to severe urinary incontinence, there was not a significant improvement in pelvic floor, in their urinary incontinence episodes after 6 or 12 weeks of therapy. So many of the prior studies that established, that say that baseline therapy has significant improvement with urinary incontinence episodes were not done in this kind of cohort where these women are older with functional impairments and more severe urinary incontinence. So this is an important clinical finding that in that cohort of women, if our first line treatment may not be as efficacious as we had previously thought. When we asked about urinary symptom bother after 6 weeks of pelvic floor training, women with physical function impairment had significantly lower changes in their UDI-6 scores, which is a standard questionnaire that we provide, compared to women with normal physical function. And further, 93% of women with normal physical function reported being better or much better after 6 weeks of pelvic floor muscle training and behavioral therapy, compared to only 69% of women with physical function impairment being better or much better. However, in both cohorts, overall satisfaction was low, with 55 to 61% of women being not at all or somewhat satisfied with their treatment. So these observations aim to begin to characterize the phenotype of geriatric incontinence. So if we follow the framework that Freed developed for frailty, whereas there are an accumulated number of deficits that occur to result in frailty, we believe that the deficit accumulation model fits very well for the geriatric incontinence syndrome. Thus, we created a model looking more like the Freed frailty or conceptual model, or a concentric model that I'll talk about in a few seconds. So, within this model, geriatric characteristics are present based on urinary incontinence severity. And what we want to do is identify now the number above which likely the geriatric incontinence phenotype would present. So in this bar graph, you can see the number of geriatric characteristics between 1 and 10, and the percent of them that are present within the participants of our cohort. And in blue is moderate urinary incontinence, and in green is severe urinary incontinence. So if we use severity as a cutoff, so in our study, we chose 2 or greater incontinence episodes per day, more for its clinical context, as well as statistically, we can see that as the number of deficits increases, more women with more severe urinary incontinence have many of those deficits. So if you look between 0 and 3, 4 and 7, 8 plus, you see more of these, higher percentage of women with more severe incontinence having more deficits. All right, my bar graph just didn't show up here. So just to summarize what we've learned so far is that lower physical performance and increased urinary incontinence episodes were correlated highly with each other. Women with poor physical performance have more urinary incontinence episodes on a 3-day bladder diary at 4.47 in comparison to 2.7 in those with normal physical function. So that kind of further supports this close relationship between physical performance or physical function impairment as well in more severe urinary incontinence episodes. After 6 and 12 weeks of pelvic floor muscle therapy, or the first line treatment for urinary incontinence, we saw that there was a decrease in urinary incontinence episodes, but this decrease is very modest, and it doesn't seem to improve the overall satisfaction with urinary incontinence episodes in this cohort. But of great importance, we were able to identify key clinical characteristics in this cohort to inform the development of domains to compose a diagnostic index in order to potentially identify the geriatric incontinence syndrome in clinical practice. And this is all modeled based on how they developed the free frailty index that I'll show you here. So here I basically list key clinical characteristics in this cohort, and they include moderate to more severe urinary incontinence episodes, functional impairment that's defined by the short physical performance battery, mobility disability, the presence of fatigue or exhaustion, this is a valid measure of frailty, presence of weakness defined by grip strength, the presence of sarcopenia, cognitive impairment, as well as obesity. So when we consider these domains or characteristics, the next step that we have to do is begin to validate the number of these characteristics that need to be present, similar to how 4 out of the 7 characteristics have to be present when we are considering how we define or how we diagnose frailty. We want to do the same thing with the geriatric incontinence syndrome to understand how we can identify these women in our clinical practice. So this is a schematic of the concentric framework that is much more commonly used and applied for geriatric syndrome. So instead of it being this linear relationship that may not be able to simultaneously consider multiple different clinical features, we are proposing that it's this concentric framework. And this is kind of what we've developed for geriatric incontinence. You know, if you think about the conceptual frameworks that were present earlier, what's important about this concentric framework is that we are considering that there is this interdependence and associations between these potentially accumulated effects of impairments that can result in the geriatric incontinence syndrome. And if we go from left to right and consider the evidence-based characteristics, it's important. So physiologic depletion of estrogen after menopause causes a loss of urethral smooth and skeletal muscle, as well as a shortening in the urethral urethra because of skeletal muscle loss, as well as poor urethral coaptation, which is the loss of the internal vasculature of the urethra. And this can all contribute to a specific type of incontinence that happens in older women. We consider function impairment. It's been shown to be present in 62% of older women. We showed it in our study as well, so that's been confirmed as being a really important feature of geriatric incontinence. Mobility impairment features low extremity weakness that has a 2-fold higher prevalence among women with urinary incontinence and falls. In addition, decreased physical activity is associated with increased urinary incontinence in older as well as in older women. We were able to show that sarcopenia is more prevalent or develops more frequently in women who develop urinary incontinence after the age of 70 in our Health ABC study. And if we consider cognitive impairment, there's a 1.4 higher risk of cognitive impairment among women with urinary incontinence. So these are the features that we know so far that can go into this concentric model that are interrelated as well as independently associated with urinary incontinence. So we reconstructed this conceptual framework to more accurately represent the potential of a deficit accumulation model for the clinical phenotype of the geriatric incontinence syndrome. So we then plan to extend our knowledge into urinary incontinence by providing more strong characteristics of how to identify this into clinical practice. If we look at other data, our work aligns with other findings. When we consider functional decline, this study supports our findings from the Health ABC study by showing that physical performance declines at a greater magnitude among older women with urinary incontinence compared to those who were continent. Mobility is also an important factor, as we showed earlier. In this cross-sectional study of older adults with overactive bladder, they show that slower gait speed was associated with higher likelihood of urgency incontinence. And Tatiana Santos, who's a urogynecologist in Baltimore, also interested in geriatric syndromes, also conducted a cross-sectional analysis of 20 older women to investigate their pelvic floor and physical function measures, and showed similar findings. Mixed incontinence was most prevalent, that we all know. Short physical performance scores were present, or physical function impairment defined as an SPDB. In this study, less than 10 were present in 35% of participants. SPP did not correlate with urinary incontinence measures in this study, but it was a very small sample size. So if we consider our next steps, to further understand how to clinically identify and characterize the incontinence syndrome, we have partnered with our Pepper Center to develop a geriatric incontinence clinic. And this is a multi-specialty clinic, including geriatricians and urogynecologists, to comprehensively evaluate older women with urinary incontinence. Within this clinic, we're going to do a comprehensive geriatric assessment. And geriatric assessments includes the 5 M's, which is what matters most: the mind, mobility, medications, and multi-complexity, as well as of course a comprehensive incontinence assessment that's going to define the criteria to establish a diagnosis of a geriatric incontinence syndrome, as well as a way to evaluate treatment success in women with geriatric incontinence specifically, and to develop innovative treatment approaches that embraces their geriatric risk and treats their incontinence. One of the treatment approaches that we're using, that we are currently working on getting some funding to test, is a beyond the pelvic floor exercise intervention. So throughout this study and the review of the data, we've learned that skeletal muscle health is really important, as well in physical function, in the physical performance and function. And physical functional impairment is a key closely associated characteristic with more severe urinary incontinence, specifically in older women. What we hypothesize is that if we design a physical function exercise-based intervention that not only targets pelvic floor function, but also targets skeletal muscle beyond the pelvic floor, this may replace the first-line therapy for pelvic floor muscle only interventions that we're currently using now, and may be a more smarter and more specific way of addressing the global skeletal muscle impairments that are present in these women with a geriatric incontinence syndrome. So that's kind of what's next, that we hypothesize would be the next best step in treatments for urinary incontinence. So I thank you all so much for listening to this talk and for your attention, and I welcome any questions and comments.
Thank you, Dr. Parker-Autry. It's Heidi. I know it's hard to see me sitting in this big conference room. I love your work, as you know. I'm curious about the work that Chantal Dumoulin has done with the dancing and pelvic floor physical therapy intervention, which my understanding is it may do some of the mobility stuff and also maybe some of the executive function of coordinating through dance. What is your impression of that intervention and its potential in the much older adult population?
Well, I think so, Heidi. Thank you for asking that question. Dr. Dumoulin is a pelvic floor PhD trained physical therapist in Montreal. And we've actually worked together a fair amount in developing the concept of the beyond the pelvic floor intervention. So that's kind of that's a large component of what we're planning to do. We are hypothesizing that, dance modified for women who have physical function impairment, which is a modification that we'll have to make, and with pelvic floor muscle engagement, may be a smarter way of treating urinary incontinence in this cohort of women who have concomitant functional impairments and potentially cognitive impairment. Mild cognitive impairment is very common among a lot of these women with functional impairments. And so the executive task, the benefit of dance that just for everybody's sake, dance has been shown to be really impactful on executive tasks and cognitive impairment. And so by combining all of these different things of physical exercise, dance-based therapy, as well as pelvic floor therapy, we are hypothesizing that this would be a better treatment for this cohort. So thank you for bringing that up. Any other questions?
Thank you so much, Dr. Parker-Autry, for joining us this morning from Jamaica on your vacation. We are really just so grateful to have your expertise here. We're going to give you back your time. Anybody who has questions for Dr. Parker-Autry later, if you email me, I will connect you with her by email, and we can engage in a more robust conversation when she's no longer on vacation. And I'm looking forward to, she and I have been talking about how we can bring some of her compelling work here to UW. So we're working on it. So hopefully in the next few years, you'll be able to refer your patients to a program she's testing. So thank you very much. Have a wonderful day. Candace, or Dr. Parker-Autry, we are so grateful for you. Thank you.
Thank you all so much for having me. Have a great evening or day.